Good afternoon, ladies and gentlemen. Subspecialty medicine, the way of the future. Welcome to the fourth great debate. Thank you. This is our third face-to-face debate, one online. So the great debate about subspecialty medicine. My name's Torin Sengupta. I'm your moderator for this afternoon. Our teams on my right, the undefeated, undisputed heavyweight champions of the world, John Hall, Emily Harrison and Ben Dodds. The John Hall fan club is here. We'll say more about that. Their challengers, Simon Quilty, Sue Velovski and Brit Wicksteed. Please make them welcome. Before we start, I'd like to acknowledge the traditional owners of the lands upon which we meet for this wonderful conference and pay my respect to their elders, past, present and future. The order is that we have the affirmative team down the far end, the negative team here. Each speaker will get 5 minutes, the first speaker 5 minutes, the second speaker 5 minutes, the third 7. There will be a warning with a minute to go. Madam Lash in the front here is in charge of the timing. Peter, stand up. Oh, she is. Yeah, okay. She will do a demonstration tinkle. That is the demonstration tinkle. So, you will all get a chance to vote at the end of the debate for the winner. You do that through the app and you access that through the main agenda. So not your own agenda, the main agenda. If you go in there, you'll see a tab that says voting. Make sure you can see that, but that won't be live yet. We think it's fairer to wait until the end of the debate to vote rather than before. John Hall has advised that you never argue with a fool. Onlookers may not be able to tell the difference. His Facebook page, as we've observed before, famously says, "I can win an argument on any topic against any opponent." People know this and steer clear of me at parties. Often, as a sign of their great respect, they don't even invite me. Please welcome the first speaker for the affirmative and reigning champions, John Hall.
Okay, my name's John Hall. We're Team Subspecialists. I'm the founding director of the National Rural Partialist Program, and we are Team Subspecialists. You'll be hearing from me, Emily, and then Ben. Clearly, subspecialty medicine is the way of the future. This is not a question. Put simply, they are better, they are safer, they are smarter, they're worth more, and they're happier. The days of the jack of all trades and the master of none are gone. The Swiss Army knives of rural medicine are being replaced. As I roll out my knife sleeve here, I'll say to you that specialists can deliver higher quality care in their area of specialty. Highly tuned skills, specialised equipment and teams. We've got more doctors than we need in Australia at the moment. We're training more specialists. Why not use them? All, everywhere, fit for purpose, right skill, right place, right time, everywhere. So let's unpack what we mean by special. So special, the Oxford English Dictionary defines special as better, greater, otherwise different from what is usual, belonging specifically to a particular person or place, or people born from 1985 to 1995. Because as we know, everyone's a winner. You get a car, you get a car, you get a car. So why don't we use this entitlement and this special feeling, endorse it, confirm it, produce a new whole generation of subspecialty teams. So subspecialty, it's a narrow field of professional knowledge. It's used to describe an increasingly more diverse medical specialty. We also know that subspecialisation has increased as medicine has become more complex, and it's become very clear that complications decrease as the volume of cases per physician goes up. And I'm going to show you this with some evidence. They're just better, really. They can make decisions early, they can improve a patient's trajectory through the health system, they're up to date, and have the latest evidence regarding their specialty. So this is an article from the British Journal of Surgery in 2002, and it showed that high volume surgeons had far fewer complications than their low volume counterparts or generalists. 2 times higher incidence of recurrent laryngeal nerve palsy in generalist surgeons doing less than 30 cases over 6 years. The evidence is there, guys, and it's a really reputable recent article. So why wouldn't a young special millennial want to be one? Better compensation, better recognition, better status. It's all in a name, really, specialist. And we've got the data to prove it. This is a survey, a real survey from Medscape. It's a well-respected online news and info CPD service, and they do this every year. This is a real survey. Surveyed 13,000 physicians every year across 29 specialties. They found consistently specialists were paid over 100 grand more than their primary care or GP counterparts. This is a breakdown by specialty, and in Australian money, that's around about $1 million a year for these high-paid specialties. Why wouldn't you choose subspecialty training? Higher rates of pay, less work, more work-life balance. The future really is special. Relative value, let's look at this. So basically, you're getting $1 million to $1.5 million. That's about $4.3 a day. And yet we have bureaucrats in Australia that say, we shouldn't be paying rural generalists over $2,000 a day to work rurally. But it's okay. It's ethically right for us to employ 5 times the number of specialists in every rural town, pay them all $4 a day. It's what we should ethically do. They're happier. So this is the same survey that showed, would you choose your specialty again? This is real data, people. So all of the subspecialists, 99% said they would do their specialty again. Look down the bottom here. Our family medicine GP, 60% said, yeah, I'll do my specialty again. They're happier. Our society wants it. We've all had patients that have said, I want to see the best knee surgeon to do my left meniscus. We've all seen this. The way forward. What is the way forward? We're solutions focused at NARP, and what we need is single organ partialist teams in every rural hospital. Right specialist, right organ, right place, right time, every time. How do we get there? I tell you how we get there. We're calling the federal government for urgent action on the rollout of NARP. And we're going to transform our college with the help of the National Partialist Commissioner. We're going to transform our college acronym into ACRAPM, Australian College of Rural and Partialist Medicine. I'd like to thank our platinum sponsors, National Rural Partialist Program, and I'd like to thank you for listening. Thank you.
Give it up again for John Hall. We heard about, this is real data, people. That was the real John Hall. Well done. To open the batting for the negative is a rural generalist trainee and a president of the RDWA. Please welcome Brit Wicksteed. Brit.
Thank you. So my name's Brit. I'm from WA and I am the token WA person on the RDA board, and indeed this group of people here. I'm also a fledgling ASIM trainee, and above all, I'm a country kid, passionate for the country and passionate for this idea of being a jack of all trades and master of none. You may also remember me from last year's losing debate, but somehow I'm back up here again, so thank you for having me. We've been tasked to sell generalism to rural generalists, so it should be pretty simple. Thanks, John, for your words. I mean, I would agree with you that subspecialists seem to have really huge egos and not much else to offer. And I do wonder if perhaps now that you're kind of stepping away from your board role, if you wouldn't be more suited in Big Pharma with that presentation. So, good luck in your future career there. I just, to think about the future, I think let us first think of the present. My first argument is a bit of a selfish one. So of everybody here today, hands up if you work in a generalist environment and love what you do. All right, good. I was hoping for that response, but it's pretty awkward if not. Now, can you put your hands up again if within that you practice a tiny, tiny bit of subspecialty medicine, but you really love it? Few less. I think we can agree generalism here is much more fun than the subspecialist part. We enjoy treating patients as a whole, and we also enjoy putting holes in patients. And can you imagine a world where in your hospital you have a specialist for every part? You would no longer get to stick needles in things, stick tubes in things, pull fractures, or manage chronic disease. That's awful. Could you imagine? Imagine losing your skills because you had to farm out each body system to a subspecialist, or because your hospital or the government or whoever it may be has just sold its soul to this expensive and inappropriate model of working. Imagine losing all the joy in your work, because that's what happens when subspecialists are allowed to silo your patients. And I don't really understand the data that John has presented with the happiness, because I can agree, I think we can all agree that sitting around us today are some of the happiest people that you know who have chosen medicine, and you know plenty of miserable specialists who go to work every day in a tertiary hospital and have to really stop themselves from climbing up to the roof and contemplating jumping. Subspecialist medicine in rural Australia would be a thief of joy, skills, and the value that we provide to our communities. This brings me to my next point. Won't somebody please think of the children and the adults and the elderly? Not only do subspecialists do a subpar job of treating the person as a whole, they really don't add value to the communities. Subspecialists have had to spend their whole life dedicated to a tiny part of the body. They've spent so much time with their head in textbooks that they've lost their real-world skills. How can they possibly be a pillar of their community as generalists are? How can their pale complexions and weak muscles hold up in the bush? I just don't think they can. So generalists not only give care cradle to grave, they can probably give you a hand with the mustering, or change the tyre in your car if you're in a bit of a sticky situation. They might be able to provide emergency care to your family pet that you accidentally ran over in the driveway. They might be able to help you in a flood or one of the other crazy climate events that we've seen. Rural generalists must be pretty good plumbers too, because I have heard tell they really know how to fix the kitchen sink. That was a sex joke, guys. And on that note, I'll pass it over to our less capable colleagues who might deserve your pity, but certainly don't deserve your vote this evening. And just think about it, subspecialists versus generalists. If you were to suddenly drop down with a cardiac arrest right here, would you rather it be with these colleagues around you, or would you rather it be with the orthopaedic surgeons who only take care of your left little toe? Thank you.
Thank you very much, Brit. Mark Twain asked, where would men be without women? Scarce, mighty scarce. So continuing the theme of women in medicine, please welcome Emily Harrison, the second speaker for the affirmative. Emily.
Woo! Woo! I'd like to thank my distinguished colleagues for their opinion. However, mine's more important. Okay, so there was once a time when everyone agreed that sticks were better than carrots and that our national COVID response was a bit shit. But this is no longer time for fairy tales and emotions. Today, it is time for me to talk to you about some facts and the future. First, a fact: subspecialists are the way of the future. And second, I no longer believe in magical unicorns. Currently, while junior doctors still have freedom of choice, 85% are choosing subspecialty training. And why not? Why not choose subspecialty training? It is the easy option. Our subspecialty colleagues are only required to focus on one part of the body. They have less stuff to learn, and therefore it must be easier. Also means there's lots of choice when it comes to the type of subspecialist you want to be. You can be a surgeon or some type of physician. Maybe you'd like to specialise in having babies. Not the babies, just the having of the babies. For some reason, there are 5 different subspecialties of pathology. You could choose a critical care subspecialty. Then there's psychiatry, radiology, geriatrics, and don't forget all the paediatric subspecialties. In total, there are 86 subspecialty training types listed with APRA, plus a whole bunch of subspecialty and subspecialist types that are not listed. These are not made up. With so much choice, we can understand why our junior doctors are choosing subspecialty training. And let's make it even easier for them. And get rid of generalist training for good. With all training changed to subspecialty only, we are just preempting the future and saving some money along the way without the rural generalist training pathways. So, what is the way of the future? A new model of care. One that's available in every hospital, where every patient will have access to every investigation and every treatment. They'll be assessed by every subspecialty every time they present. It is subspecialty only medicine, or SOM. Think of the amazing and efficient patient-centred care that could be offered in this new model with SOM. All the doctors will be trained as subspecialists. They will be a cohesive team of subspecialists, sub-subspecialists and sub-sub-subspecialists working together for their patients, with each subspecialist giving an opinion, a diagnosis and treatment options. With SOM, we'll be able to focus all our medical workforce in centres of excellence, previously known as hospitals, and create subspecialist only medicine centres of excellence, or SOM COEs. It'll be a one-stop shop. No longer we'll be wasting time with the middleman. Navigation of the healthcare system for doctors at least will be easier than ever before. And what do we do when the cities are full of subspecialists and sub-subspecialists? Well, Dorothy can make them go rural with geographical provider numbers. And we can create rural subspecialty only medicine centres of excellence. The rural economies can only benefit from the influx of luxury car dealers and boutique coffee shops needed to support these centres of excellence. Think of the savings to be made with the whole healthcare budget focused on subspecialty only medicine, where it belongs, and we'll be getting value of money in healthcare for the first time ever. Plus, subspecialists will be able to access all the newest and most up-to-date toys, treatments and investigations. There'll be no more 6-minute consults and come back see me next week, no more wasting time and money on community-based care, no raw generalist medicine. It is time to be realistic. With less and less junior doctors choosing rural generalist training every year, time has run out for generalist medicine. We can no longer believe that the magical unicorns that are rural generalists are going to be there in the future. We need to start planning for the future that is coming, whether we like it or not. Subspecialty only medicine. Thank you.
Thank you very much, Emily, and congratulations on being brave enough to take on Peter Rutherford with a cowbell. Our second speaker for the negative is a general surgeon from Ballina. I'm told it's now the tropical wetlands of northern New South Wales. Please welcome Dr. Sue Velovski. Sue.
Thank you for the opportunity to present our case. As you can see, Brit has already presented most of the very relevant arguments, but in the next few minutes our team will also demonstrate to you, the audience, the future generalists and leaders in medicine, that subspecialty medicine is not the way of the future. It is in fact, for a lot of colleges, a lot of training bodies, the way of the most recent past, and that's where Emily has got it all wrong. As you can see, we don't need slides because as rural generalists, we are one of the best communicating groups in the medical field. The opposition clearly has nothing of real relevance to say, hence the multitude of slides and PowerPoint presentations, trying to bluff their way through their arguments. But you all know the surgical dictum, a fool with a tool is still a fool. And what about the evidence from Dr. John Hall, from the British Journal of Surgery and Medscape? But John, we're living in Australia, and the Australian data does show that rural generalists have very good outcomes. For the young doctors here considering subspecialisation, you have to remember that subspecialisation is not normal and will convince you that subspecialists are not normal creatures. In my college, the College of Surgeons, we've already done this experiment over a decade ago, and it has failed our patients, especially in rural communities. So for all of you young doctors and medical students, when you think of a subspecialist, what do you think of? You think of cardiologists, respiratory physicians, or even colorectal surgeons, or as it is now, colon and rectal surgeons. Think of a routine day of a rectal surgeon. In clinic, their first 4 patients may be men, all over the age of 60, usually far too busy or important to have followed up on their positive FOBT that their GP organised 6 months ago. And now they tell the story of a perectal bleeding, mucus discharge, constipation, diarrhoea, maybe even some weight loss, changes in the bladder. Then, down to the important stuff, the nitty-gritty. Have their parasympathetic and sympathetic nerves been affected by this cancer? Or in layman's terms, Mr. Smith, can you still have an erection? And can you ejaculate? Now remember, they only met this man 4 minutes ago. So the Australian pub test is, if my team, Brit, Simon and I, went to the casino bar tonight and sat next to some random man, would we really find out in 4 minutes about their erectile function? Oh, wait, we're in Canberra, of course we would. 5 minutes into the consult in Canberra, your rectal surgeon moves on to a clinical exam, a digital rectal exam, and usually it's a big, tall male surgeon with a size 8.5 glove. Now, for all the medical students in the audience, this is a little genteel, petite, size 5 glove. So, and this would be a size 8 glove. Can you imagine how much damage a size 8 glove might cause? People go to jail for lesser things. When rectal surgeons go to conferences, they have expensive dinners at expensive restaurants sponsored by expensive companies who sell balloon catheters and tell you in their latest study that it takes at least 15 millimetres of mercury to produce a fart. Not normal. Dermatologists, apparently the most difficult training program, 6 years of learning, 7 layers of skin, over 1,000 diagnoses to do what? Punch biopsies, usually unnecessary. Renal physicians learn 200 glomerulonephritides, but what is the usual treatment? Yeah, the student just said it over there, steroids and fluid restriction. Fluid restriction is a form of torture in Guantanamo Bay. Cardiologists, oh wait, did you say you heard a systolic murmur? You need to ring Jeff, he's the aortic valve registrar. I only deal with the mitral valve. Are you taking the piss out of me? Oh, piss, urologists. Oh, testicular torsion, you better ring the general surgeons. We only do testicular torsion in Dolly Parton hours, 9 till 5. So, Peter wants me to finish, and I will, because she is the CEO. Thanks, Peter. Peter, let me finish with a cautionary tale to all you young doctors. If you want to look after the aortic valve like Dr. John Hall and his team want you to do, go right ahead. But don't choose a subspecialty because there is no item number for whole of body care. It's a discussion we definitely have to have, but let's keep doing it and not harm our patients. If you choose subspecialty medicine, as the opposition would like you to do, there's a reasonable chance you'll become utterly disinterested. It'll be too late to retrain. You'll become mentally and physically constipated with your life, and constipated enough that you'll develop anal manometry pressures of 25 millimetres of mercury, develop an anal fissure, and your colorectal colleagues will send you off to the gold standard treatment, which is cosmetic cowboy Botox injections to relax your anal sphincter. Can you imagine Dr. John Hall with Botox in his anal sphincter?
Bring it!
Subspecialty medicine is not the way of the future. Thank you.
You can always tell a surgeon, you just can't tell them much. Our third speaker, Ben Dodds, hails from Mackay. So like Dennis Passion, he's a North Queenslander pretending to be a Tasmanian. I have it on good authority he wears RMs with shorts on the beach. And he's still in his 20s, even though his hobbies would make you think otherwise. He is the current Tasmanian Rural Doctor of the Year and the President of the Rural Doctors Association of Tasmania, the third speaker for the affirmative. Please welcome Ben Dodds.
Woo! Go Ben!
Thank you, Torrin. Ladies and gentlemen, general practice is in crisis, and we, the affirmative, strongly believe that generalist medicine is not the way of the future. In fact, specialist and subspecialist medicine is the way of the future. My learned colleagues over here, they were so nervous for this debate that they've been popping propranolol pills just to get up and argue for something that they don't believe in. Brit, we bet you last time and we'll beat you again this time as well. I note that John presented solid data on happiness and you just presented a simple opinion. I would argue that your rural generalist who can come and help you on the farm, your orthopaedic surgeon can probably build a solid fence, and your O&G can probably pull a calf out of a cow. I'm not going to say that one because it's highly offensive. I'm going to skip that one. Sue, I've never met Sue before, and I'm not going to say that one. But I've just met you for the first time, and all I heard was rectums, DREs, erectile function, farts, and not a lot of evidence for any of it. If you'd skipped the GP and gone straight to the surgeon, you'd remove that 6-month wait and have excellent outcomes for that patient. And Simon, I think you were calling us country bumpkins before, weren't you? You don't even believe in journalism, mate. But on with the show, if I can make it work. Thank you. Ladies and gentlemen, general practice is in crisis. Major peak bodies are describing the unsustainability of general practice and how the health of the nation is suffering. Indeed, medical students are choosing to shy away from general practice and pursue specialist training. Only 13.8% of medical students are considering general practice as a career. That means 86% of students may end up in specialist training. We've heard from my colleague, Dr. John Hall, that we need to nurture this interest in specialist medicine with the National Rural Partialist Program. On the other end of the spectrum, we are bleeding GPs more than ever before with high levels of burnout and poor work-life balance. Simply put, general practice cannot sustain the healthcare of this nation. After years of money being spent in the Australian General Practice Training Program, we're yet to see any real change in the distribution of general practice trainees and fellow GPs. This graphic demonstrates that over 60% of AGPT registrars are practicing in MMM1 metropolitan areas. That means that only 18% of AGPT registrars are practicing in our rural MMM3 to 7. This workforce policy has been ineffective to solve the maldistribution of doctors. Our specialist-only medicine centres of excellence, as proposed by Dr. Harrison, is the solution for subspecialist medicine. It is the way of the future. General practice is in crisis. Income lags behind specialists, with the only Australian exception being pathologists. The Medicare freeze has significantly damaged the reputation and attractability of general practice, and now young doctors are turning to specialist medicine. Interestingly, the community perception of value has meant that paying for a specialist and paying for their advice is normal, compared to the outrage of paying a gap fee for a GP. Funding a specialist-led model is easily done with the fantastic community buy-in of the right advice the first time. Ladies and gentlemen, specialist medicine is the way of the future. Even our prominent members of the GP community are giving up on general practice. We remain undervalued, underpaid, underprioritised and overstretched. We are losing our own values and beliefs regarding the structure of generalist-led medicine and undermining our own career, putting off students and early career doctors from seeing any value in generalist-based medicine. In the wise words of ACRM President Dr. Chalmers this morning, general practice in crisis is being thrown around like there is no tomorrow, and we, the affirmative, believe there is no tomorrow for generalist medicine. Subspecialist medicine is the way of the future. General practice is in crisis because GP training is too short to deal with the complexities of multi-morbidity and complex patients that exist in modern day medicine. We need specialist-led healthcare that can interact with each other and provide the right specialist at the right time for every patient. The problems that we face with general practice are not unique to Australia, and internationally we'll continue to see the demise of general practice. We must accept that there are patients that GPs don't have the skills to manage. And ladies and gentlemen, it's already started. The rural specialist takeover. Dr. Simon Quilty can't advocate for generalist medicine. He is a mole within the RDAA. He's here to take over the generalist agenda and push the National Rural Partialist Program. His own words, that rural consultant specialists are the backbone of small regional hospitals. I'll be not lectured by this man on generalist medicine. This conference will not be lectured by this man on generalist medicine. Not now, not ever. And another, Dr. Brit Wicksteed. She's no generalist. She's an ASIM trainee. She's hiding in the shadows. She's taking over. She's going to be an AMC person soon. She'll be attracted to our National Partialist Program. She'll accredit it. Rural Specialist Centres for Excellence. She'll love them. So, ladies and gentlemen, in conclusion, overall, the community expects specialist-led care, the right decisions and safe patient outcomes every single time. Centralised care delivered within the hospital setting, our SOM COE and our SOM COE, nothing like a new acronym. No more silos, no more chasing referrals, no more chasing results, all the patient's information at your fingertips. We'll have early decision making with the latest evidence-based medicine and the latest technology and infrastructure to help support the patient's journey. So we know that specialists are happier, highly respected, properly remunerated and deliver the best care for patients. Early career doctors are shunning general practice. They've seen the writing on the wall. They're wanting a policy change that enables and supports rural specialist pathways. We strongly believe as the affirmative that subspecialist medicine is the way of the future, and our National Rural Partialist Commissioner and NARP can lead the way in this policy direction. And when I'm looking for a job in 2 years' time, don't hold this against me.
Our third and final speaker needs no introduction, but I'll introduce him anyway. Simon Quilty is a physician. He's on the board of RDAA, and he spoke today saying that there's no more exciting or interesting job in the world than being a general physician in Katherine. He has had to reconsider that since he's contemplated John Hall's lower gastrointestinal tract and what Botox might do to that and the rest of John. Simon has also worked at the Purple House and continues to in Alice Springs. He's been a fervent and passionate advocate for climate change, but has somewhat changed his views since moving to northern New South Wales. Please welcome Simon Quilty.
Woo! Thank you, that's Professor Quilty. Ben, I'm so impressed at how well you speak English from Tasmania. It's terrific. And John and Emily and Ben, you together are most convincing. My team doesn't need slides, we are orators. But your slides are entertaining, and congratulations, and I'd urge all of you to vote for the affirmative. They're clearly correct. So let me tell you a little bit about myself. I'm a professor of the mitral valve, but not just the mitral valve, the anterior leaflet chordae. And it is so lovely to be in Canberra. I came from Mossman this morning, and I love being in little country towns like this. It's so quaint. I saw a cow on the way to town. Gorgeous thing. I went to Parramatta once. I had to get my Maserati serviced. There were no cows on the way to Parramatta, though. So anyway, let me tell you about the anterior mitral valve chordae, because I know I've caught your interest. There's some really exciting research coming out about it, the anterior mitral valve. Mecamulanib is a medication that will make it the strongest chordae ever and will make people live long lives, happy. It is perhaps the most important part of our bodies and unrecognised probably by all of you, but only a specialist, super specialist would understand that. And there's a new college initiative to have 70 more mitral valve cardiologists trained in the next 3 years. And I have some rooms, and I'm working with a posterior mitral valve chordae cardiologist. And I've left my cards on the table, and you're all welcome to refer anyone with a mitral valve to me, because we need to save lives. Now, actually, I'm Simon Quilty, and I've spent a lot of time in Katherine, and this is a load of bullshit. You can have my bow tie, and there's nothing that a generalist can't have, and I dare you to challenge me. Go on, challenge me. I can throw a unicorn over a fence. So I just want to recap our arguments. It's clear that these buffoons over here in the corner, and Ben, who speaks really good English for a Tasmanian, don't get it at all. And I can see that they're struggling, and I know that you can all see that they're struggling, and I'm really grateful that you'll be voting for us. A happy doctor's a good doctor, and variety's the spice of life. And I mean, we can all see that Ben has quite high anal pressures. You could see him today. And it's because he's anxious and he knows he can't win the argument. And so humans aren't a bag of organs. They're interesting and they're delightful and they're wonderful and they're members of our community, and they don't need to be chopped up by multiple specialists. And they don't need to go into hospitals full of siloed care. They want to get to know the person who looks after them, and they really actually want to know that that person cares about them. And I know all of you guys in the audience understand that, and I'm appealing to your emotions now to vote for us. Ego kills, and it's quite clear that John Hall down there at the end has way too much ego. You're the ex-president, mate. And so sensibility will prevail today. And as Sue said, I'm going to keep it short. I'm not even going to get to the bell because I don't need 7 minutes. I know that you're going to vote for us. But Sue said a fool with a tool is still a fool. But I'd say that a fool with a tool is probably a tool. Thank you, everybody.
Ladies and gentlemen, a big hand please for all of our debaters. On the affirmative, John Hall, Emily Harrison, Ben Dodds, and the challengers Simon, Sue and Brit. We will now open the voting and put that on screen. So that'll come up on the screen in a moment. Open your app, go to the agenda, the main agenda, go to this session, and then you'll see the voting tab. So that'll come up in just a moment. The affirmative team is John, Emily and Ben. The negative team is Simon, Sue and Brit. So hop on and vote. So the champions versus the challengers. The champions are the affirmative, the challengers the negative. Vote early, vote often, vote once. So we have 73-27, 113 votes.
Come on, people!
Come on.
Yeah, you know what you're
Can
going
they
to do.
catch up? What's the fair margin? 75-25, 74-26, 168 votes.
It's like scrap paper. Oh dear. I did win. I think we could declare
The
a
challengers
winner.
are Simon, Sue and Brit. The negative, the champions are John, Emily and Ben. It's 2674, 226 votes.
No.
I think we're going to have to call
You
it,
guys have to
going
do it
once,
next year,
going twice. The challengers have it. Please a big hand for the challengers.
It's such a special thing to
They win first prize, which is a night out with John Hall. I thank you all for your participation. I'll leave you with this thought. A human being should be able to change a diaper, plan an invasion, butcher a hog, con a ship, design a building, write a sonnet, balance accounts, build a wall, set a bone, comfort the dying, take orders, give orders, cooperate, act alone, solve equations, analyse a new problem, pitch manure, program a computer, cook a tasty meal, fight efficiently, die gallantly. Specialisation is for insects. So thank you for taking part in the debate, and thanks again to our teams. Big final round of applause. The housekeeping is to advise you that the Acrom AGM is in 10 minutes. We will need everyone to vacate the room as it's for Acrom members only. So we do need you to leave the room and then re-enter if you're an Acrom member. We need to rescan you for record-keeping purposes. So thank you all, and we'll see many of you at the AGM. Thanks everyone.